think when you're really trying to overhaul your health, you have to have friends that are overhauling it too. So if your friends were all eating crappy food and drinking too much and whatever, now what, you're not going to hang out with anybody? You kind of need some new friends that are doing the same thing.
Yeah.
And so building that is all, that social piece is huge.
This is Dr. Chetan Sathya. Thank you for joining us for this episode of Northwell Health's 20-Minute Health Talk. Today, we are joined by Emily Kaplan, the co-founder of Broken Science and Medfix. Thank you so much for being with us.
Thanks for having me.
It was awesome how we connected. I know you had the opportunity to speak at HLTH, which is one of our biggest kind of health tech conferences in the country. How was that experience?
Well, yeah, it was a little nerve-wracking, to be honest, because I wouldn't say that I'm like anti-pharma, although I get put in that box quite frequently. And it was Callie Means and I on stage together. And so I wasn't really sure how it was going to be received, because a lot of that audience is obviously people within the pharmaceutical industry. And it was received so well that I would do it again in a heartbeat. But I was a little more nervous for that audience than some of the others that I speak to. I mean, when I speak at, medical schools or medical conferences, it's usually doctors who are coming because they want to hear about preventative medicine in ways that they may not be, in their normal establishment. But that was sort of a, oh boy, I hope this goes well.
I can imagine. Well, listen, it's something that I think you and I were speaking a little bit about, is you've done such an incredible job kind of speaking to different groups, right, in the work that you do. And you were here in Long Island doing that right now.
Yeah, well, we have this 2-day seminar through Medfix that's really working with coaches, although we always have doctors that come to the seminar. And it's 2 days just to look at how the food you eat gets converted into energy or gets converted into mitochondrial damage, which would lead to chronic disease. And so our premise is basically that through dietary and lifestyle interventions. So most of our affiliates are also CrossFit gyms. They have the movement piece down perfectly. So we spend some time talking about movement, but more of it sort of scaling for special populations. So how do you get people to come into the gym who aren't currently coming into the gym? The stat is we have about 20% of the country going to the gym, but it's really the 80% that need to go. And we have more people going to the gym now than ever in American history. And yet the rates of chronic disease are going up. But it's not just working out, right? Okay. You have to tackle this diet piece. And so there's this old expression of like, you can't work your way out of a bad diet. And I think this course allows any coach or doctor to start to learn the things that are really the mechanisms of action that drive chronically high levels of insulin, or we go into reactive oxygen species, which is really what we see in seed oils. So a lot of people will talk about seed oils are bad, but they say it's because of inflammation. And it kind of drives me nuts because I'm like, inflammation is just a reaction. You want to know, why is it causing inflammation? And so with reactive oxygen species, we go into an hour-long lecture about how it works. But the takeaway is essentially it's a signaling molecule in the body, and it signals to the cell if it's full or not. And so when your reactive oxygen species is low, the cell is saying, okay, I can take on more. When your insulin is high, your body's saying store. So in combination, when you have a high carbohydrate, high sugar diet with lots of seed oils, you are overfilling your cells. So the amino acids then spill into the bloodstream, your triglycerides go up, and you end up with fat in places you're not supposed to. I mean, we call it ectopic fat, but when I'm talking to lay people, I just say, like, you're not supposed to have fat in your liver, right? Your pancreas needs to work properly. And when you're on these kinds of, sort of standard American diets, you're actually eating diametrically opposed to how the body was designed to work. So it's you could say it's a nutrition course, but it's not really. It's sort of like a biology, physiology course for personal trainers and coaches and doctors and healthcare workers that hadn't gotten that education before.
So doctors come for this course. How many of them are telling you that they were just never taught about this in medical school and this is totally new to them?
Totally new. And I think registered dietitians also, I think that, registered dietitians and doctors and really the establishment has always had to prescribe the dietary guidelines, right? So this is like one of these MAHA issues that I've been a big fan of, because I think, frankly, if I'm in a coma and I'm morbidly obese, this is a great time to overhaul my diet. I don't have any control over it. Well, same when you have a kid who's in the hospital for something. They're eating 80% of the diet is like processed cheese and bread. What are you doing? Like, how are we? And so school systems, the military, and hospitals all have to follow the dietary guidelines. Registered dietitians do go through a very rigorous training, but they're taught on the dietary guidelines. And so when you start to peel these layers back, you realize they're sort of the information army of the application of the dietary guidelines. And so they're not learning about chronically high levels of insulin leading to, the connection with lipolysis and storage. And so when you start to understand, if I have chronically high levels of insulin, my body is not able to eat the fat on my body adequately for energy. So I am always hungry and I am always tired.
Yep.
Because I don't have energy on my body I can utilize. And then I hope that really does build sympathy for the person you see walking on the street who's really overweight. And people are like, oh, she can afford to skip a meal. Well, actually, she can't because she's internally starving because she's in this glycolytic pathway. And so as long as she's there, she's not accessing the fat on her body. And the carbohydrates are a quick fuel source. So she gets a little bit of energy and then she crashes. And she's not going to get more until she either switches over into a fat adapted pathway or she starts eating more carbs. And I mean, I think for me, when you get into the sort of how does this impact us as a country or frankly as a world at this point, it's so clear to me that like there's a level of freedom that we're taking from people. So if the average American is like done by 4:00 and they can't wait to get home from work so they can lay on their couch and eat their pizza, that's half your life.
Yeah.
That you're not spending with your kids or your grandkids or your friends. I think that's truly
it's a lot of wasted time.
It's a wasted life.
Yeah.
But you're doing exactly what you were told to do, right? You're eating this low fat, high carb diet that everybody said was heart healthy. And so you're compliant. And so for me, that builds even more sympathy. Like this person is exhausted and tired. Nobody wants to have a body like that where you feel like there's no energy coming from it. I mean, it affects your brain, right? It affects the entire system. And I mean, I really believe we're just energy beings, right? And so how we use and process energy is the whole game. And as we age, that starts to shut down. But a lot of these chronic diseases used to be called diseases of aging, but now we see them in kids. Well, why is that? It's because the dose of the poison is higher and it's a cumulative effect. So it used to be, menopausal women had beer bellies. Well, no, it's because when your estrogen declines, you become more likely to be insulin resistant. So if you're not upping your fat and your protein and you're decreasing your carbohydrates, yes, you will get a belly fat the same way a guy does, but it's not just inevitable aging.
Yeah.
That's fat in places there you're not supposed to have fat. That's organ fat. Why are we dismissing it as just, this is just what happens? Well, it shouldn't.
It shouldn't. No.
Yeah.
And we know that type of fat is deadly.
Right.
Do you, it's interesting because when we talk about thinking about whole person healthcare, right, beyond the four walls of our hospital, we talk about a lot of things, social determinants of health, other lifestyle modifications, and so on. And I think this is really critical. And I think it's something you and I agree on is nutrition, exercise, absolutely essential. How are you seeing doctors through your program, right, integrate this into their everyday practice? Because as we discussed earlier, you sometimes just see a patient once a year.
Yeah.
Right. You don't really know what happens after that. You say, hey, listen, go to the gym a little bit more, eat healthier.
Right.
How are you taking that to the next level of implementation?
Well, so I think there's twofold. We have some doctors who are just like all in and have opened Medfix gyms within their medical practices.
Tell us a little bit about the Medfix gyms as well.
Yeah. So the Medfix gym is basically we have a program called Spark. That's after you take our course, you can go back to your gym if you're an affiliate, and it's 4 weeks. And it's bare bones. So like what you learn over the weekend is more intensive. When you implement Spark, it's us coaching you on how to implement this in your practice or in your gym. And so it really starts with just tracking food and learning like what's a protein. I mean, most people don't know what a carbohydrate is. So you can't speak to them on the level of this is why this does this and this is why it does that really until week 4 of that implementation program. But it's an onboarding program. So it really, anybody who wants to be helping with the nutrition piece, that gives them all the tools that they need to do it. The doctors are doing that in tandem, right? So some of them, like we have this great ER doctor in LA, and he has people who come in, and if they're having, sort of like a psychotic episode, once they're stabilized, he goes in and he does a nutrition lecture with them about how the food they're eating is making their anxiety worse or making the depression worse. He's taken people outside and just done like air squats with them, get them moving, get the blood pumping, right? Like help them sort of re-regulate. And he speaks to them about all of these Medfix concepts in a sort of condensed hour-long talk he has with them, that he is, privileged within his system enough that they let him do that. And he's in the process of trying to overhaul all of the food that is fed to people in the ER. And he's using our resources to do all of that. So that's one example. Somebody who opens a Medfix gym within their practice looks more like somebody in private practice who has the, the space and the ability to offer a gym, or we have a couple of people who have just turned patient rooms into very small gyms. And so they'll hire a coach to come in, and that coach will do a combination of food lectures and movement lectures and get them moving. And sometimes it's like 3 or 4 people, but they offer it as an add-on to their private practice. So if we think you need to lose 20 pounds, like you can do it anywhere. But if you want to do it under our sort of like supervised program, what we recommend is MetFix, which really just stands for metabolic fix. And then they can sort of onboard them into that program. And so they have somebody working with them on diet, and they have somebody, usually it's the same person, doing the exercise piece. And there's, we have somebody who's in like near Hilton Head, and he has this like beautiful facility. He's built out this big, beautiful gym. And for him, I think he loves that he can go, he works out there 4 times a week. So he sees his patients regularly in a sort of social, casual environment, but he can encourage them, whether it's in the workout or it's the lecture piece or whatever. And then when he sees them again, he sees the difference they've made, and he's been kind of on that evolution with them, which is really beautiful. And I think that's most doctors I talk to, they got into this whole thing and worked so hard to help heal and hold the hand of the patient that they're sitting with and guide them through all the things that have gone wrong, but also give them hope that they can change them. And now usually that looks like pulling out your prescription pad, writing a prescription, or giving them a referral because you don't have time to help with these lifestyle pieces. So partnering with a MetFix coach really allows you to find somebody who knows how to do this and will help and report back to you, right? So the MetFix coach might give you weekly reports, like Emily skipped 2 appointments this week, or she's down 15 pounds, her A1C, let's do her A1C again so we can normalize it. We have an ability for our medical association to do telehealth. So we have this rural healthcare crisis, right? And so with more than, I think we have about 150 locations now, MetFix gyms. If you're in a rural area, one of the things that we do in our weekend seminar is really go through blood panels. And what do these look like? What do they mean? How can you talk to people about them? Because, again, like it used to be, it was so stressful, but the way, when I was younger, you'd get your blood work and then the doctor would have you come back.
Yeah.
You'd be terrified if they're going to find something. Whereas now I think more and more people just get the results online. They skip the return appointment. Well, that's another one of these pieces. If you have somebody who's, A1C is pre-diabetic, I always say that is an incredible opportunity. Yeah. It's an inflection point you can get in, and you can drive real change before it becomes a chronic condition this person is going to be diagnosed with. So our coaches can do that. They can sort of look at that stuff. Now, if they can't get the blood panels, what do? And a lot of people in rural areas don't have a doctor within a couple, hours drive for them. So our doctors are able to do that through telehealth, nice. Which is pretty cool because we're kind of solving for some of those problems. I'm very clear that like personal trainers cannot be getting people off medication. We are not giving medical advice.
Yep.
But if you have so we have some people who are doing type 2 diabetes classes, which means they've gone out into their community and they've basically recruited people who have type 2 diabetes to come in and start working out and start learning how to eat whole foods, right? So let's get you off the processed stuff. Let's ditch the sugar and see what changes we can make happen in the gym for the cost of your gym membership, right? Now with those, and that's profound because I think a lot of those people would never, ever have walked into the gym. But when they know they're only going to be in a class with other people that have the same thing. So there's actually a couple people who are also doing like women in menopause. Okay. So it's about building strength, eating right, learning about your bones. And I think that class is another one where it's like the women want to be together and they want to talk about their experiences. And so it becomes like a support group. And then after they've, accomplished some goal, they can join the general gym classes if they want to.
Yeah.
And so it's an onboarding for those gyms. But under those, I think if you have people who have a lot of ailments, it's really important you have a doctor you can talk to. And so that is sort of the symbiosis between those two entities.
That's incredible. So you're creating a community. And you're also empowering physicians to take that community to the next level, right?
Right.
Like they can actually empower patients. They themselves can improve.
I just think think of like a family health doctor 100 years ago, right? You'd ride out on your horse.
They were part of the,
You'd go, you'd know everybody because you'd see them at church on the weekend or whatever. Like the community, that health component used to just be an extension of all of these other social things that were part of the fabric of the community. I think we need to bring that back. I don't think that you are going to get health in the true preventative optimization that most people want by going to the doctor for 12 minutes once a year.
Yep.
Right. I just don't.
No.
I don't think the doctor satisfaction surveys that I look at are heartbreaking. Suicide rates are off the charts. Depression is off the charts. People wanting to leave the field with the high cost of liability insurance. People aren't making nearly as much money as they used to. So you have this esteemed figure within any community who's not getting the validation for any of the points that they would have gotten if they had entered the field 50 years ago. And they're not driving the change they want to. So it's hugely frustrating. I understand you have somebody come to you and you want to help them. And what do? You have 10 minutes to figure out how to match their symptoms to the right prescription. And then you have to go into a billing system where there are codes that may or may not match up with what you want. So you're playing around with how do I code for this thing that's not really this thing, because we don't really know if it's that thing, but this would cover it. So I'm going to code it for that. And then the patient's record gets, kind of messed up because it says they have things that they may or may not have, but it was a way of covering the bill. I just told this story recently to our team, but I went to the doctor just for a routine thing. Mm-hmm. 2 doctors in the practice. I think there's 3 PAs. There were 12 people sitting outside at a bank of phones. And so I was like, what are those people doing? And the answer was dealing with insurance.
Yeah, it's crazy.
So I'm like, you have 2 doctors and they have to pay all of these people just to handle the billing? That's money that should go in their pocket. I'm paying insurance so I can go to the doctor. I want the doctor to get paid. I want the doctor to feel validated. I want the doctor to have more time with me. But you're going to have to see more patients if you have to pay 12 people. None of that works. The community-based approach works much better. And frankly, it works on a social level where I owned 6 gyms myself with my husband. And then he split off and got another job, and I took over 3 and rebranded them and implemented a lot of nutrition into those gyms. And one of the things that was really interesting was that we're in small towns, right? So 10, 15,000 people in the town. And we did these marketing campaigns where you'd show a before and an after picture of the person. And we had these things where when people got to their, goal weight, we always set goals inside the gym and outside the gym. But when they hit their goal, they could do a photo shoot. And I hire a professional photographer and a hairdresser and a makeup artist, and it was all women. So it was super fun, right? And everybody got into it. But what I realized was that those marketing pieces worked so well because everybody knew each other.
Yeah.
So I get a postcard and it's got, you're the superintendent of the school system. And I'm like, holy crap, what have you been doing? It's not a fake model. It's somebody that you actually see. And I think in some ways, this is the role of, religion in communities. You have leaders who speak to you, and then you have the people go out and sort of be like, I don't know. Do you believe that? Are you going to do that? What are you doing this holiday? But then they start to sort of agree on some commonality. And I think when you're really trying to overhaul your health, you have to have friends that are overhauling it too. So if your friends were all eating crappy food and drinking too much and whatever, now what, you're not going to hang out with anybody? You kind of need some new friends that are doing the same thing.
Yeah.
And so building that social piece is huge. It's a massive part of why people will stay and why that consistency will be there. You're looking forward to seeing the other people that you're going to the group with, right? And if I'm skeptical and I don't know this is going to work, but I start to see you're getting amazing results, it's not a sales pitch. It's a point of validation. It's a scientific principle that you see at play that makes you now buy in. Meeting people where they're presenting an idea about something that causes a big reaction in you is always an opportunity for you to be like, wait, where's that coming from? Because I know when I'm confident in information, I'm settled. And I'm sort of okay with you telling me I'm wrong because I know we're going to have an interesting conversation. The defensiveness and the political polarizing stuff is to the detriment of the average citizen. Yet it's the average citizen who's unable to go to Thanksgiving dinner with their, grandparents or their uncle because they think they're so apart. And I actually think health is the great equalizer.
This work with Medfix, right, with the gyms, this is an adjunct to any medical therapy that's needed.
Yes.
Right, as you mentioned, you guys don't give medical advice, but you're working in tandem with physicians who might want to also, have medications prescribed or so on. But what I find interesting is, if you look at Function Health and so on and all the labs that are being drawn nowadays, right?
Yeah.
It's so hard, I think, for physicians to know what's happening between those long visits annually, right? What do I need to do next to approach that abnormality in the blood work? Is it worth doing something? And I think rather than just relying on medications only, which is an important part, pharmacotherapy there, you're providing an ongoing opportunity there for lifestyle modification, and I presume potentially getting people off medications
all the time
sooner than they might have.
Yeah, I mean, we have people who are like, I've had type 2 diabetes for a decade.
Yeah.
And no one ever told me that if I stopped eating carbohydrates, I could reduce my A1C within 4 months.
Yeah.
It's very fast.
Yeah.
And I think like that's the kind of thing where if I'm a doctor, I might actually be reluctant to tell you that it's the carbohydrates because I'm not going to be there to monitor you.
Yeah.
And so there's
such a good point.
There's an ethical piece to this too, which is that if I'm seeing you in the gym 3 times a week, I can walk you through what it's going to be really hard when you go off of those and you're going to feel like garbage. It's not going to be easy. Your body has been reliant on them in that system of energy for a decade more, right? Same with kids and fatty liver. You can reverse fatty liver really fast. 1 in 10 American kids has a liver that looks like a raging alcoholic. That's all sugar driven. So I think like there's a lot of things like that, but you might be nervous to say, oh, just cut this thing. You don't know, is somebody going to do it all at once and then face, other problems? You're responsible for that. Whereas if you're working with a coach, they can sort of slowly get them off and slowly see how they are feeling and, how are they sleeping better? So like when I had my gyms, I used to always say to people, there's not much you can do in terms of diet and exercise for a month that's going to kill you or that's going to make you, now there obviously are extreme examples to this, but for the average person, you could decide to do a fast for 30 days and you might be really pissed at me about it, but chances are you're not going to die, right? Now, we're not going to do anything that extreme, but my point is always just like, try it. And then like, let's get your labs again. And things like A1C is 3 months, right? So like you're still going to have some of that hangover from before they came, but usually within a month, you can see real improvements in the blood. And that's basic. That's like a basic lipid panel, right? I think, I'm a protective person. And I think it does drive me crazy with some of these integrative medicine, functional medicine, some of these labs, like, are you kidding me? We are really majoring in the minor.
Yeah.
You know what I mean?
Yes.
And I don't think that the significance that we see in peer review is conclusive. I have a lot of problems with peer review, but I think like that's a money grab in a way that I don't like, know?
And that could be the downside, right?
Right.
With the current movement around that functional medicine. Is it actually going to swing the other way?
Right.
If we don't tackle it thoughtfully like you are.
Yeah. So I'm always like, you don't need to buy anything.
Yeah.
Like this is the when we talk about sort of lower income populations really struggling with chronic disease.
Ask you about that, yeah.
We have a lot of people on staff. I'll send them into the grocery store. And there's one who's in Maine who does the best videos where he goes in and he grabs like, Hot Pockets and a soda and whatever. And then he grabs like a rotisserie chicken and a bottle of water and, like a salad mix. And ours is always the same or a little bit less. So even when people say like, I can't afford to eat healthy, it's education. It's like, no, you don't understand what is healthy and what isn't, right? And those packaged foods add up. And my thing is you eat more. So like I'll do carnivore for like a month every year, just sort of like a cleanse. And I'm always struck by the fact that like if I eat a ribeye for lunch, like I'm not hungry for dinner.
Yeah.
Once you're in that fat adapted pathway and your body can really utilize the energy it has as, fat on your body, you're not hungry. So you actually end up eating less. So, even if a ribeye is $25, if that's all you're eating every day versus eating tons of junk food, which is $5 here, $5 there, you're probably spending more than $25 a day. So I think some of that is a narrative fallacy that we are trying to tackle with real world, like go to the supermarket, grab these things. What does it look like? What does it cost? How do you feel after you eat it? After you eat the Doritos, you want another bag of Doritos, right? After you eat the rotisserie chicken, you probably are full. You don't want to eat anymore.
Got it. So this program for low-income folks, it's something that is achievable.
Yeah,
right?
I would love to get it covered by Medicare and Medicaid. That's like a long-term goal. I think like we could drive government spend down so significantly if we could tackle these chronic diseases with lifestyle change. And I think, don't get me started on the bureaucracy involved in all of that, but like this is a meaningful thing. And I think, we have a big app that we're launching within the next month. We're testing it now. And it really makes these things so easy. So like even a doctor who wanted to get involved but wasn't ready to sort of jump in all the way, joining our medical society is great. We have a lot of tools for doctors that I think are hugely useful. And we have something called Journal Club, where we take apart journal articles so you can start to learn the problems.
So that's what we have in the hospital too.
Yeah.
So
well, it's based on that.
You guys have one, yeah.
We have one, and we really try to, I mean, we did one recently on testosterone that was 7 hours. So like sometimes it's a little bit too much. But it is, like, the point is, if you go to those regularly, you can read medical journals on your own in a way that I think most people, you know, you may have taken research methods in med school, right? But like you don't really understand like how, you know, like intention to treat analysis. Like, what does that mean? People aren't finishing the study? You know, like on some basic levels, there's things that you're sort of like, this is not as solid as it should be. Whereas I feel like Medfix is just clinical significance. That's all we're really measuring. Like, is it working or not? Where do we see the points of validation? So the app will allow us to really be tracking that more, which I hope is really a precursor to us being able to work with bigger, whether it's hospital systems or government industry, you know, that will help in terms of funding the program. Because I think I get text messages from affiliates all the time about reversing A1C. And I'm like, you guys don't understand how, like, what a big deal this is. Like, it's a massive deal. Most people don't go to the doctor and ever reverse their type 2 diabetes. It's not even a discussion. And you're doing it in the gym for $200 a month. You know, like, that's crazy. So I'm excited. That app also has a lot of really fun things. Like, you can take a picture of your plate and it'll take all your macros. So it's super easy.
Okay.
Or we have this thing called the Daily Fix, which is a free workout of the day, a free recipe of the day, and a free reading of the day. So it's brain, body, belly is the idea. And so we have tons of people cooking for the first time, or saying they're cooking again, you know, for the first time in 20 years. Those are all can be made in 15 minutes. They're not expensive. They're easy. We have videos that show you exactly like when to put the thing in the pot, when to take it out, right? So we're demystifying. I think it's very hard to reverse chronic disease and really engage in your health from a nutrition standpoint without learning how to cook.
Yeah.
And so the goal with all of that is to make it simple. And so our amazing tech team, Mia and Ethan, who run up all of our tech for us, came up with this idea that you can take a picture of your refrigerator, and then using this AI model that they built, it'll tell you what Daily Fix recipes you can make based on the ingredients you have in your fridge. Oh, really? So there's no excuses.
It'll assess. Wow.
Yeah. And so even if you don't have the right ingredients, it will suggest modifications so that you can make something healthy based on what you have. Like, no DoorDash. We're going to do it right from the fridge. So, and that will link the doctors up more easily with the affiliate owners and stuff like that.
What's the app called?
This is going to be Medfix.
Medfix, okay.
Medfix.
Okay.
Yeah.
Well, definitely excited to.
Yeah. We should have you beta test it too. Yeah, that'd be cool.
Absolutely. So Emily, I want to learn a little bit more about you, right? And what brought you to this movement? What brought you to start Broken Science? And, you know, you early in your career were a journalist.
Yep.
You know, I'm just wondering if you can talk a little bit about what drove you to be involved and how did Broken Science start?
So there's a long story and a short story. So I'll give you kind of in between.
Yeah, you're perfect.
I think, you know, as a journalist back over, I think it was like 23 years ago, I was mostly covering business, growth, and development in Las Vegas. So I had worked for PC World covering Congress and sort of got a front row seat to the way that lobbyists influence things and the way that industry tries to innovate, and sometimes regulation holds things up. And so that was incredible. I had gotten my master's at Northwestern.
Oh, I went there for
I knew
surgery.
That.
Yeah. Cool.
So that was that was a very rigorous program, and I did really well in it and loved it. And so when I was in Vegas, my now husband at the time was getting a master's in exercise physiology. And he was like, if you want to cover a really big story, you should look at these dietary guidelines. And I was like, what do you mean? Okay. And he was like, it doesn't add up in terms of the way the body is designed to work. And so we started peeling the layers back. Mm-hmm. And I'm like sort of a workaholic. So I had so much overtime at the newspaper that they basically forced me on a month's vacation because they were like, we can't pay you overtime for all of these hours. So, and I was sort of like, I don't really even care. Right. But like, they were like, no, like because of the way the unions work and whatever, like you have to just like go somewhere for a month, like take a month off. But of course I wasn't going to do that. So I decided to work on a documentary where I went around. And so I interviewed Mark Hegstad, who was the architect of the dietary guidelines, and this guy, Nick Modern, who helped put them all together. And then that I ended up getting a job at ABC in New York. So that didn't end up, I've never published that, but when they just redid the dietary guidelines, I shared some of that interview, which is horrible because I hadn't worked in TV and I like did not know what I was doing.
Yeah.
But I mean, it was an incredible project because I did realize like there were all these studies that had been done from the 70s through the 90s that were looking at saturated fat and cholesterol, and they were buried. I mean, some of them weren't published for 10 years. And there was nothing wrong with them. I mean, the Minnesota coronary heart experiment is like one of my favorite, trials ever done. It was done in like an elderly home, and they went to such lengths that they actually took the butter and wrapped it in gold so it looked just like the margarine. So like it was truly randomized in this like perfect way. But I was sort of like, what is going on? And I had learned a lot about the government when I was in DC. And so I became sort of fascinated with nutrition policy and sort of the ability for people to take epidemiology, like food frequency questionnaires. And they're saying that that's scientific. Or even this is where you and I may disagree a little bit, but like the public health stuff, it's like you can look at a population and you can try and come up with indicators of what's working or why are these people sicker or more healthy. But those are all corollary.
Yeah.
And then they get transferred into the news, certainly, and sound causal.
As causation, yeah.
And then, I think epidemiology, from my lens, is a great precursor to a trial, but it is not a substitute for one. And so when you look at the early nutrition stuff, it's almost all epidemiology. And I think a lot of that was because it was too cost prohibitive to do a randomized controlled trial on humans. Humans are hard to study, right? So fair enough, but that led us down a path that we just assumed was conclusive. And in doing that, we have created a lot of disease. And so that was sort of my introduction to metabolic health, was this sort of like deep dive into what is this all about? And Gary Taubes and Nina Teicholz and a lot of people who I'm now friends with were working on that. We were all sort of in that same problem at that same time. And then I went on to ABC and I covered murder mostly for 2020. So I like complex, high stress situations, sort of like where I thrive. And then I went on to work for a company that was based in the Middle East and in the US, sort of matchmaking American interests to things that were happening in the GCC region over there. And then, and then we had these gyms, which really had started as my husband's. And then he became the head of research for Peter Attia.
Oh.
And so he left to go do that. Okay. And I took the 6 gyms, we sold 3 and rebranded the 3 that we had. We had been part of a franchise, which was pretty horrible. So I was like, let's leave that and I'll just own these 3 and sort of pivot them into like being little health centers for middle-aged women. And in the process of doing that, I realized there was so much research on women that was horrible, like just horrible. So I developed this curriculum for the people in our gyms that was really looking at women's health issues that could be handled with diet and exercise. So like the importance of weight-bearing exercise for osteoporosis. So we would do a month on that. And the coaches would get the talking points and the studies to share, and it helped elevate them. And while I was doing that, I got to know Greg Glassman, who was the founder of CrossFit. And Greg, when he built the CrossFit pyramid, which is sort of the hierarchy of need and of ability, nutrition was always at the base, but he never really explained it. And so when we got together after he sold CrossFit, we both were really struck by things like how much misinformation there was and confusion there was in the health space. And we met with a lot of people like Jay Bhattacharya, who had been really canceled through COVID. Mm-hmm. And a lot of people were saying to us, like, this is the first time that scientists have been really maligned for doing what they thought was right. Like people in the medical space that are esteemed at Stanford and Harvard, and they're being called like fringe epidemiologists, like what is going on here? But Greg and I both were like, no, this isn't the first time. Like this has been going on in the nutrition world for a long time. And so we realized we had to do a deep dive into the philosophy of science, which people think is a little bit of a deviation, and it's really not, because so much of the way that we practice medicine today or public health is based on these ideas that come from the philosophy of science. And so in a very shortened version, David Hume denies induction and Karl Popper picks it up and runs with it. And that leads to things like p-values or, all the Neyman Pearson stuff, right? And so we have this influx of statistical methods sort of trying to determine what is valid and what is not in a scientific experiment. But if you look at things like p-values, you realize it's not actually a tool of validation at all. It's only telling you whether the data in the hypothesis has been tested or not. So when you're looking at the null, you're not testing the null. You have an assumption the null is true. And then you're looking at the data you get from the intervention and you're finding some connection between these two. That doesn't tell you your intervention works or not. It doesn't tell you that your intervention is going to have a predictable outcome. So that then brings us sort of to the replication crisis and this notion that most research findings are false, which is John Iannotti's paper, which has been more cited than any other research paper. And so people would say, like, well, why do we have this replication crisis? And then they'd go to things like COVID and scientists being maligned. And for me, it really explains how the corruption has been able to enter the system. Because if you're conflating math and science, there's no proof in science. It's about uncertainty.
Mm-hmm.
And you're trying to be a little bit less uncertain every time, but you should never be certain. When you start using these statistical methods, you're giving this sort of false hope of certainty that doesn't exist. And so the research is actually, when you go to the sort of the negative side of things, right, or the more malicious side, it allows me as industry to come in and actually really control outcomes in ways that I don't think most people, even in the research world, are taught or see. So being able to go out there and say, I was wrong, people think it means like you're going to get canceled and everyone's going to hate you and you're discredited. It should do the opposite.
Yeah.
But now I think, oh, wow, this person they're allowing themselves to pivot because they think the new information is powerful enough. I am way more likely to listen to you.
And I think one of the things that I do agree with you on here is we have become too worried about questioning certain things,
Mm-hmm.
right? It's okay to ask questions. It's okay to reevaluate things. When I look at what's happening at the NIH right now, and I wrote about this in the Washington Post, there are things that I fundamentally disagree with. But there are a whole host of things that I think that are very exciting that are happening at the NIH, that are actually going to transform research, that are going to make it better, that are going to improve the peer review process, that are going to allocate funds more efficiently, right? And I think it's that spirit that's really important in these conversations. How do you toe the line between wanting to question things, right, with an open mind, having an open mind, understanding that trends may exist, there's some sort of thing there that you might want to evaluate, and at the same time not taking away or not creating tremendous distrust with maybe more well-established scientific evidence, right? Things that have thousands of studies that back them up, meta-analyses, randomized controlled trials, and so on that back it up for decades, right? How do you kind of draw that line? Because it is an important conversation in public health, right? Otherwise, we're at this point right now where distrust is very high. And I agree with you. I think things could have been done better. It's always easy to go in hindsight, but as public health, I don't think we've done the greatest job communicating uncertainty or being open to new thoughts. What's your response to that? Because it's a really hard line to toe.
Yeah, I mean, I think for me, I can't help but ask questions. And so I'm like less interested in being diplomatic and more interested in being like, if somebody comes at me with something where they seem very, very certain, well, then I think it's my job to ask you questions because honestly, it's selfish. If you're really confident and you're sure you have this right,
you should be able to respond
and I
to
see
it.
all these holes in it, then either I'm wrong or you're wrong. And so I'll learn from you if you're like, well, no, actually they figured that out and it's something I haven't been exposed to or I don't know yet. So I think there's two things I would say from the sort of communication side. We have infantilized the American public to a point where people are just outright resentful. And I think that's where the mistrust comes from. It's sort of like this principle of a noble lie. Like we're going to tell everybody to take this drug when really we know that it's only 1 in 200 people benefit from it. But the benefit we've decided is worth it for the other people. You can't do that, right? I mean, I think like that is the difference for me between public health and medicine. Public health is about policy and medicine is about treating the patient in front of you.
Mm-hmm.
The idea that public health is telling medicine what to do now, I have a huge problem with. I think you got to be able to recognize, I mean, in women's health, you see this a lot, right? Because so many of the trials have never been done on women. So if you're told to prescribe me the same medication that you would prescribe to my brother, without looking at my history and the fact that I'm a woman, but that's the policy, you're not doing your job as a doctor. You're not treating me, you're treating the population. That's public health. I think there needs to be more church and state between those two. Doctors need to be empowered to do what they see is working in their practice, that clinical significance piece. And they need to be empowered to, get the guidelines, know who's funding the research, know how how was the sausage made on this one? That's a lot of time. I mean, you look at these concierge doctors who are charging extreme amounts of money, they have a whole research team. The average doctor in a hospital doesn't have that. So we've got an equity problem in terms of resources that doctors get, which I think, our Medical Society of Broken Science is actually really trying to help with that. So we can be your research arm. We can, give you studies or look at studies that you think are sound and tell you why there are questions about it or why it wouldn't work for women, even if it does seem to be working for men. That takes a lot of work, right? And so I think it's a miscommunication that is hugely unfortunate from the patient perspective, but not necessarily the fault of the doctor. We have so much research coming out. It's like research overload. It's impossible to
actually.
And so even when people come to me and they say like, oh, well, have you, you say this, but I have this study. I'm like, I can find a study on anything that says what I want it to say. You've got to look at how the study was done, right? And that takes time. I think the miscommunication stuff has led us into I would say, the optimist in me says it's actually a wonderful opportunity to go back and teach people what science is.
I agree. Yeah.
And so I think it's a tragedy that we, have treated our medical professionals the way we have when it may not entirely be on their shoulders. But at the same time, it means like if the patient now is doing their own research and coming more informed to the table, maybe that drives doctors a little crazy because they're like, no, I'm the expert. But if you're open to it, they might have spent weeks
way more time on an
researching
issue.
the latest literature that you haven't had time to, and you could learn from that. But I think we have to put the egos.
Check. That I completely agree. We have to have humility, right? I mean, to think that we can know as much about every issue as someone who's researching, I mean, it's just not possible. And I think it's not realistic. And we do have to have a ton of humility there. So when a patient comes in, right, and I agree. I mean, I have so many families that know far more than I do about some of the issues, and I actually learn a lot from them. And I think it's our responsibility, you're right, when it comes to clinical decisions and so on, to infuse those decisions with as much, of the evidence that we have, and to make a joint decision on that actual therapeutic or surgery or whatever the decision's being made. But what about, your initiative is focused on teaching folks, right, how to interpret these studies, how to look at the evidence, which I tremendously do appreciate, right? Because I think otherwise you get into a situation of what I referred to earlier, where somebody might pull a study, and this is happening, that really doesn't meet any scientific muster, if any. And they're going to compare that to studies that have a very high bar of scientific merit. And they're going to try to leverage that to say that, this is the one thing that should be done. So in your opinion, do you think you're able to get through to enough people to prevent what I'm referring to right now, in that the flip side of this is that, let's just say everybody starts finding a little study here and there and saying, hey, this is my evidence, this is all I need not to do this, not to do treatment A or B. How are you going to scale that? How do you think about that? What are you seeing across the country?
Well, yeah, and I think that's really where the relationship becomes essential. If I trust you and I feel you're listening to me and I bring you a study and you have the time, right? This is all luxury. But if you have the time to sit down with me and be like, I love that you brought this in, but let's talk about why this isn't going to actually have the clinical significance that you think it has, right? And I think this is where, as a doctor, you need to be empowered to say, in my practice, I know this one works because I've prescribed it to, 10 other people just like you. And they started where you are and now they're here, right? I don't think that's our job at Broken Science. I think that's the job of a good doctor. I think our job at Broken Science is to say to, medical professionals and patients, our medical society is also open to patients.
Oh, okay. Awesome.
Is to say to them, like, when you're a patient, you're super vulnerable. You walk in, you don't want to challenge the authority. You want them to care for you. There's a dynamic there you cannot ignore. So how do you respectfully ask those questions? How do you respectfully present a study? And ideally, how have you educated yourself on what is good or bad research enough that when you sit down with them, you can say, hey, I know you think this is the gold standard study, and I've looked at that one too. But these were really interesting to me because they address these variables that I'm also facing that this one doesn't. So you're elevating the conversation where they know enough that they're not just, going on Google and printing out whatever, or ChatGPT, even worse, right? Like, my doctor says I need to do this. I don't want to. What should I know, right? Like, that's a good starting place, but there's so much more to it. And it has to be respect both ways, right?
Agreed.
And I think this goes to your idea of certainty in public health. It's like, people in a crisis want to defer to authority because it allows them to relax and feel like a grown-up's in charge. I'm okay. But you do that enough times when you don't have the certainty, and now no one trusts you, right? So like you see this with kids with anxiety, where like when they push the boundary on something, so like you say like, okay, like, no candy tonight. And they're just a pain in the butt. So you're like, fine, like you can have the candy. But what it's doing is it's actually wearing down your authority. And it creates anxiety. And I see this all the time. I mean, like, I'm in Boston and the school system is pretty liberal and everybody's got their things and whatever. And so like, my daughter came home and I told her she had to clean her room. And she was like, Mom, it makes me really uncomfortable when you say that. And I was like, hey, what? What are you talking about? And she had been getting out of things like math at school by saying it made her uncomfortable. Right? Like, this is insane.
Yeah.
But she also has anxiety. And I think part of that is because she's a real talker and she's a pusher. And I don't know where she gets any of that from. But I think that will all serve her really well. But while she's a kid, she needs to know the grownups are in charge. And the rules are the rules. And you can't get out of math.
Yeah.
Right?
Yeah.
And so I think you take that on a larger level and you have, officials in government telling you that they know a certain thing. And I think, this is part of the pushback you see on Bobby Kennedy is that I've gone through and done like a deep dive into like allegations against him. And, I think his biggest problem is he's super provocative, but most of the time he's asking questions. That's how he phrases it. I mean, he's a trial attorney. He knows how to do that, right? But I actually think that we need more people asking questions. If you're really confident in your stance on vaccines or whatever it may be, then somebody's saying like, how do you know that's right? How are you so sure of that? It doesn't unhinge you.
Yeah.
It makes you realize, oh, we haven't done a good enough job of explaining how these studies work or what these outcomes are, or we haven't done a good enough job at looking at these adverse reactions. Maybe it's not autism, but if we have all these moms out there saying that something happened to their kids and it's not vaccines, what is it? I get concerned by the politicalization of health. Mm-hmm. And I think in some ways that started with nutrition, where we had the government telling us what to eat, right? Was that helpful or harmful? When you do the autopsy on that, it doesn't actually seem to have helped a whole lot, right? And so I think there are areas where you have to sort of be able to ask questions and be challenging while being respectful, but not have the other side then just emotionally respond to you and shut you down. That doesn't help either side. Does that make sense?
Yeah, absolutely. And I mean, I think it summarizes the moment we're in beautifully, and we have to be okay with those conversations. And to your point, when I spend time with folks in the MAHA movement, I mean, very few of them are actually anti-vaxxers, right? They might have little questions about elements like you mentioned and so on, but they vaccinate their kids. Dr. Bhattacharya speak about that as well. They're just asking questions about nuanced aspects of it, and I think it's okay to have that conversation.
Meeting people where they're presenting an idea about something that causes a big reaction in you is always an opportunity for you to be like, wait, where is that coming from? Because I know when I'm confident in information, I'm settled. And I'm sort of okay with you telling me I'm wrong because I know we're going to have an interesting conversation. The defensiveness and the political polarizing stuff is to the detriment of the average citizen. Yet it's the average citizen who's unable to go to Thanksgiving dinner with their grandparents or their uncle because they think they're so apart. And I actually think health is the great equalizer. We all want our kids to be healthy. We don't want our kids to have chronic disease. We don't want to live sick for the majority of our life. Do we have all the answers on that? No, but can we agree that those are commonalities we all share? I can't imagine anybody saying they don't want that, right?
Yeah.
And I think that we've been there, the modern environment has just really pushed people into these silos where they identify with the silo, and then it becomes offensive if somebody challenges one of the tenets of that silo. That's a huge mistake, because it keeps us separate. And I think it keeps us from sort of trying to bring about some of the changes that we've talked about.
Yeah.
Now, I know that if a public official stands up there and they say, you know what, we're not really sure where this came from, and we don't really know the impact of it yet, but we are doing everything in our power to study this, and we're going to report back to you what we find. And that's going to take a few months. So in the meantime, take whatever precautions you feel are necessary. If you're sick or immunocompromised or you have these things, we highly recommend these things. You know, like that to me at least. And then like you get new information the next day. You don't have to wait months. You can come out and say, we had these researchers who pulled this study from this other country that we didn't know about yesterday. This is indicating this. This is going to make us pivot in this way, either more extreme or not. But again, like we don't know. This is new. We're trying to suss this up and figure it out. And I think likewise, things like cancer, where we've had this, you know, was it like 79 or 78, that Nixon declared a war on cancer, and the cancer rates are only worse.
Yeah.
It might be time to really stop and just say, like, are we looking at this correctly or not? So like Tom Seyfried is a good friend of mine who has the metabolic theory of cancer, that the cancer is actually in the mitochondria, not the nucleus. And he has these really beautiful experiments that informed his theory, where he moves the cancer cell or the cancer from the mitochondria to a healthy cell, and it develops cancer. And you repeat that by doing it from the nucleus, and it doesn't. And I have never gotten anybody in the cancer world to be able to explain to me, they're called nuclear transfer experiments, how is that possible if it's in the nucleus? Like just at the base level, right? Like that sort of undoes the somatic theory of cancer. And yet people think he's like this fringe guy. He's really not. And his book is very hard to get through, and you know, a deep dive. I'll send you a copy if you haven't read it before. But things like that, I'm like, you can't just say he's wrong because it's not how we do it. You have to say he's wrong because there's something flawed in what he is saying. And I think we have these lofty experts and establishments that are so wedded to the hypothesis or the theory that they were trained on. And that's not really intellectual honesty. So I think, again, it's this ability to both be confident and be humble and say, I know I don't know everything. Now, I was trained on everything this way, but that's pretty interesting. I'd like to look into that. So probably 15 years ago, I was doing a story on Tom, and I called around to like all these cancer experts, and their answer across the board was, if that was something real, I would have seen it. I was like, well, you haven't.
Why hasn't it come out in studies?
Do you want to look at it? I'll send you all the stuff. And they're like, no, I don't have time.
They don't want to. Yeah.
Well, wait, what? Yeah. Like you may be treating this as a genetic disease when it's a mitochondrial disease. That doesn't light you up. You know what I mean?
Yeah.
Like we need more of that. Yeah. And maybe that happens with younger people, right? That have the luxury of time and research. But I think as I get older, I just have more questions. You know what I mean?
But this is also where the incentivization from the NIH and other organizations matters, right? You know, if you're incentivizing well-established models, it's going to keep having those same models, right?
Correct.
Taking risk is tough in academia. Yeah. Tougher than we think.
Yeah.
And negative findings don't get published, right? I know the NIH is working on that. And I think those are all those different areas. And we could spend 6 or 7 hours talking about everything, peer review and so on. So I do think that we need to rethink the incentives for academia across the board. But, you know, going back to what you said when it comes to public health, it's difficult, right? I mean, during COVID, those first months, we were operating with incomplete information. I think decisions were, you know, people were trying to make decisions quickly that would keep large swaths of the population safe. And I do think over time, there was not a constructive discussion on what went wrong. Right. What can we change? There was not a pivot, right, to the same efficiency that you talk. It is because you kind of dig your heels in.
And then you're going to have to say we were wrong. And that's another thing people have a very hard time with.
We should be okay with that.
We should be. And as a citizen, I'd be grateful for that.
Yeah. I think that's a key point. You know, how do we get more comfortable? So let me ask you a question then. The future of public health, right? This is a crossroads we're at right now.
Yep.
What does the future of public health look like for the next pandemic, let's say, or the next major crisis we'll have, or just our basic public health infrastructure? Because we need better infrastructure, we need investment, we need better data. I would argue that some of that is, if anything, lacking right now, and we're not in a better place necessarily. But that aside, from an expert communicator, journalist, what is the path forward? Like how do we think about public health going forward when it comes to communicating the next
Yeah, I
pandemic?
mean, I think things like the pandemic, what would have been, if I had a magic wand, what I would have done is I would have had Trump be like, I'm going on a diet and we're going to take over the airwaves for an hour every day and we're going to do a countrywide workout, right? Let's bring people together because, it was like the CDC reported 99% of COVID deaths were people who had a comorbidity. And then there's an asterisk basically saying like the remaining 1% were probably undiagnosed, right? Or didn't know they had a disease. But so for me, it's like, let's look at like, why are we at such risk for a virus? It's because most people are sick with a chronic disease. So we can prepare and put billions of dollars into a pandemic response, or we can actually look at the root cause of this vulnerability. The root cause is chronic disease. So let's, in the meantime, while we're waiting for the next pandemic,
let's start taking
solve
preventative
this
measures.
health crisis that we have that is making the majority of our country vulnerable for a virus that really shouldn't be a problem, right? You didn't have a chronic disease, you weren't going to die. Now, they didn't know that at first. But they also we didn't have a denominator. We didn't really know the death count. That got botched statistically so badly, right? That like somebody with stage 4 cancer dies of stage 4 cancer in the hospital, they're labeled a COVID death. Now, I've looked a lot into death certificates and the codification, and it's a mess across the board, right? States do it differently. The final cause of death, gets a mark versus like what led to that final cause. You see this with pneumonia and things like that, right? So my feeling is like, we will probably have some other outbreak crisis. Now, how you handle that, you have to really understand what the risk factors are for that thing. And we may not have realized all of that right away, but traditionally, that viruses are going to impact people who have weaker systems than those who don't. So if we really care about protecting the populace, we need to make the populace more robust in their health, right? And that's not going to help everybody, but it would certainly have helped a lot if we could have said like, okay, we've got 80% of the population is at risk for COVID. So we've got to get these people moving and we've got to get them eating right. We kept the bars open, but closed the gyms, right? We could have done that and brought the country together, I think. I mean, imagine Trump doing a workout video every day. Like everybody would have watched, right? And if we had things like, the Daily Fix recipes going out and people figuring out like what food was making them more vulnerable. I mean, everybody wore a mask. What if you said to everybody, hey, what if you just stop having soda during this period? Just cut out the soda because it'll make you less at risk for an adverse event.
So are people going to listen though? So there's two parts of this, right?
Yeah.
One, I would say that on the line of behavior change, and I think that's the intersection of work, by the way, that your MetFix gyms are really working at, and I love, because I think behavior change is very difficult for clinicians to think about, for public health folks to think about at this stage.
Yep.
And I think you building that community, that trust, those relationships is huge. But let's say a pandemic hits right now, right? Even if you're asking folks to cut out sodas, to go to the gym, is that going to be well received? And have we politicized it too much now that it depends who's saying it, right? I mean, is that any different than masking?
Yeah, and I mean, this is like I think we are so down the rabbit hole of people not trusting that it's going to be a hard recovery. But generally speaking, transparency is the antidote. So if you had it where, and no one's ever going to agree to this, right? But like you had the meetings for the pandemic response medical team where they're looking at the studies and they're arguing with each other, and that's shared with the public, right? So you're seeing how the sausage is made. Then I think people, they may not watch 6 hours of people in a meeting arguing about what the research says and what the best protocol forward is. But if they want to,
they could.
And they'll see this wasn't, some industry coming in to sell their medication. This was a group of people who were really thoughtful about what we knew and what we didn't know. And they put their best guess forward and they made it optional for you to comply or not based on their best guess. I mean, the buy-in piece, like you start mandating things and you're going to immediately have people saying like, no way, I'm not doing that just because the government told me, right? That was a big mistake, I think. I think you probably would have had higher compliance with anything without it being forced on people. And I think if you show people how we came to this decision, then you're going to have people being like, well, they didn't look at this study and they disregarded that study. Okay, fine. But you're seeing there was a process. At this point, I think most people don't think there was a process. I think they think like pharma came in told people what to do, and the officials that are just puppets for industry went out and did what they were told. You really wanted, I mean, it would be painful for a lot of people. But if you're doing that work behind closed doors, then you should be proud of it.
Yeah.
And maybe it holds people a little more accountable. So like you actually are going to read all the studies because you know you're going to be filmed in the meeting.
Yeah.
Right?
Yeah.
Whereas I feel like, Scott Atlas has said several times that he would go to those meetings and it was really clear that nobody else had been looking at the research. And so I think like that's very frustrating. And it doesn't build trust for the larger community if they just see some guy getting up at a podium and saying, you guys need to do this. And if you don't, you're not going to be allowed in emergency rooms. But there's no explanation. And I think that's the sort of that you're treating people like grownups. You may not understand all of this stuff, but we're not going to assume you understand none.
Yeah.
And we know better. So do what we say. No grownups like that, right?
Yeah.
Nobody likes that.
Yeah.
Whereas if you say we debated this for several days, there's a lot of mixed opinions, but collectively we've agreed that we think this is the best course of action. Please feel free to watch the 3 days of meetings. We have a list of the hundreds of studies that we reviewed. Make it available. The internet's great for stuff like that. People will go through all of it. And you could also then get feedback from people that you would be open to that said, oh, you guys should look at Sweden, right? Or you should look at these other places that weren't part of your initial roundup of research. You're giving people buy-in and a seat at the table when you do something like that I think allows them to relax.
Yeah. And it doesn't mean that the prevalent evidence-backed strategy is not going to be the accepted one. But it means there's an open town hall on it, right? There's a discussion.
Yeah, but it also
there's an opportunity for debate. And you considered, like you didn't just shoot down other ideas.
Right. And I think in that process, it would be mind-blowing to me if the people at the table didn't also walk away with a better knowledge and understanding of things.
Yep.
And so again, it's sort of this idea of like, are we just going in and sort of dictating what people need to hear from us? Or are we actually being intellectually honest that we don't know and that's okay? And that as we learn more, we'll change. I mean, for me, it's like Bayes again, right? It's like we have this prior information. This is the information we're relying on, but we're constantly bringing in new information and reevaluating. So being able to go out there and say, I was wrong, people think it means like you're going to get canceled and everyone's going to hate you and you're discredited. It should do the opposite.
Yeah.
But now I think, oh, wow, this person they're allowing themselves to pivot because they think the new information is powerful enough. I am way more likely to listen to you.
Yeah.
Way more, because it's interesting to me that you're honest.
Yeah.
That's rare.
That's like relationship 101, right? When you meet somebody, I mean, how do you start building that relationship?
Right.
How do you not think in a silo, in an echo chamber? And I think on whatever side listeners or we are on, we're far too siloed, and I appreciate the work you're doing and try to break down those silos.
Yeah, I mean, I just think nothing interesting in life is really zero sum. Mm-hmm. And so if you think of it that way, it's not that I'm right and you're wrong. And that is how everybody behaves in these public realms now. It's missing some undercurrent of both like humanity and the fun bits of like, of course I'm not 100% right about anything. Thank God. My life would be so boring if I were, right? Yeah. I have nothing left to learn. Give me a break. And anybody who acts that way should be questioned. That's my feeling.
Yeah. Emily, we are at time. I would love to, talk about so many other things. Hopefully we can have you on another time.
I'd love to.
But thank you for being here with us today.
Thanks for having me. It was great.
Thank you.